So, we welcome all to this session of Top Video Journal Film. There is some change. Dr. Shah has to go to some other hall, so we invite him first to present his paper.
262. ये हाँ बस
Physician, first heal thyself.
Who are you?
I am God. You surgeons endeavor tirelessly to benefit your patients and science. Yet it is sad that you are not paying attention to your own well-being, to the ergonomics of surgery. Posture perfect. Ergonomics for the ophthalmic surgeon. The fundamental fact is that your limbs are supported by the body core. So, it is only natural that stresses on the limbs will mean direct stress and strain to the neck, shoulders, and back. And the weaker your core, the more the impact. Let us closely evaluate the elements that will enhance comfort and efficiency in the operating room. Ergonomics of the surgeon's chair. We see varieties of awkward operating chairs, ranging from simple stools to chairs without meaningful back or elbow support. Forward flexion is often the natural posture during surgeries. Operating without a back support aggravates the weight-bearing stress on the vertebral facet joints. This recurrent and persistent trauma may lead to arthritic changes and restrictions within the joints. Similarly, in order to maintain steady hands while gripping fine instruments for a prolonged period, if there is no elbow support, the entire stress is transmitted to the shoulders and upper back, leading to chronic fatigue and tightness in these muscles. Ergonomics of an ideal surgeon's chair. An ideal chair height is one where the surgeon's feet can rest on the floor. A seat that is too high may force the surgeon to move forward to a point where it is difficult to maintain the S shape of the spine. Backrest should support a large part of the back, particularly the lower back, and should conform to the natural curve of the spine. A good lumbar support is when the ears, the shoulders, and the pelvis all fall into one line. Armrests that are too low result in unsupported elbows. Contrarily, armrests that are too high restrict the range of movement at your wrists and may put undue strain on the small muscles of the hand. Therefore, surgeons, invest in a chair that has suitable back and armrests, which are easily adjustable in the seated position. Ergonomics of the operating microscope. While you pay a lot of attention to its optical details, the ergonomic aspects of a microscope are often neglected. The eyepieces of the microscope should be tiltable so as to be aligned with the surgeon's line of sight. If not, it may lead to undue flexion for tall surgeons or undue extension of the neck for short surgeons. Not only this, the microscope should be lightweight and easy to maneuver. As more and more external attachments get added onto the microscope, it not only becomes heavier, but also ergonomically awkward. Ergonomics of the foot pedal and operating table. It is important to have a foot pedal with a minimum range of travel so as to keep the muscles of the ankle and foot relaxed. Wireless, lightweight foot pedals give ease and extra maneuverability for both the surgeon and the OR staff. Similarly, specially customized contoured tables with a smaller base suited to temporal surgeries are the need of the day. Operating room ergonomics. Although a lot is being said about posture, seldom are the ergonomics of the space where surgeons spend a large part of their working lives discussed. We often see that cables may run across the floor, creating a threat for falls and injuries. It is wise that the electricity, gas, and networking cables be dropped from the ceiling using a pendant, keeping provision for futuristic upgrades. If this is not possible, all efforts should be made for safe cable management. Ergonomics for the patient and assisting staff. Often the most neglected during surgery are the assistants and patients themselves. In this era of topical anesthesia, where patient cooperation is key, making them comfortable using adjustable tables, tiltable headrests, and soft cushioning support makes the surgical experience pleasant. Stereoscopic viewing through assistant microscopes or conveniently placed viewing monitors make assisting more efficient and comfortable. How can you surgeons safeguard your health at the workplace? Well, it is quite simple. Invest in your health. Take time out, even if it means between surgeries. And who better than your own colleagues to give you an advice?
I really don't think about the long-term consequences of what you do every day. I found that after about 10 to 15 years, I was developing constant chronic neck pain and upper back pain. And there's no doubt it was the positioning at the microscope was leading to the problem. Therefore, I started on a regimen of exercise to really emphasize strength in the core of the body. And it really has helped my core strength and that I'm in less discomfort. In addition, we incorporated the 3D system in the operating room. I don't have to position myself in the oculars. I can sit back in whatever relaxed position I want. I would urge all ophthalmologists, those who are just starting in practice, and certainly those that have been practicing for a long time, to consider routine exercise.
So attention to ergonomics is very important. One of the most important things is that if you sit straight on temporally to make a temporal clear corneal incision, your right hand is going to be squeezed into a very unergonomic position. If I offset my body and also the microscope about 10 degrees to the left, it made for a much more comfortable and ergonomic entry into the eye.
Here are some simple exercises all of you can do. So, my message to you is, be aware of and take measures to improve your work ergonomics. For in the end, it is so simple. If you want a miracle, be the miracle.
So, thank you very much for this elaboration.
Any questions, sir? Thank you so much. Dr. Oshin is here. Your presentation is next. Is it okay? Ready? So Dr. Oshin will be presenting a video film titled Extended Orbicularis Myectomy under tumescent anesthesia for benign essential blepharospasm.
A 64-year-old lady with benign essential blepharospasm presented to our clinic for treatment options. She had tried botulinum toxin injections and was found to be refractory to the same. Due to her near constant spasm with pseudoapraxia of lid opening, she was functionally blind and hence requested remedy. Extended orbicularis myectomy surgery was thus discussed and planned. This procedure aims at excision of the protractors of eyelid, which include pretarsal, preseptal and orbital parts of orbicularis oculi of the upper eyelid,
Video.
the lateral raphe of orbicularis just temporal to the lateral canthus, extended orbicularis myectomy surgery was thus discussed and planned. This procedure aims at excision of the protractors of eyelid, which include pretarsal, preseptal and orbital parts of orbicularis oculi of the upper eyelid, the lateral raphe of orbicularis just temporal to the lateral canthus, corrugator supercilii, and the procerus muscle. The procedure is performed under tumescent anesthesia using Klein's solution. Klein's solution is prepared by adding 30 ml of 2% lignocaine hydrochloride, 20 ml of 0.5% bupivacaine hydrochloride, 3 vials of adrenaline bitartrate in 1:1 lakh concentration, 1 vial of 4 mg dexamethasone, and 1 vial of reconstituted hyaluronidase into 250 ml of normal saline. An upper eyelid crease is marked and Klein solution is injected in the upper eyelid and brow region. The skin is incised with monopolar radiofrequency cautery. The pretarsal part of orbicularis is addressed first. The sheet of muscle is dissected posteriorly from the underlying tarsus and anteriorly from the skin. Care is taken to preserve the subdermal vessels that can be appreciated during the anterior dissection. While approaching towards the free eyelid margin, visible hair follicle basis is considered as endpoint of the dissection. The pretarsal orbicularis is removed from canthus to canthus. Klein solution allows good hemostasis and a nearly bloodless field. The preseptal part is then dissected away from the septum posteriorly. Pre-eponeurotic fat may prolapse during this step. It is then dissected from the skin anteriorly. The preseptal dissection is guided anteriorly by the lowermost brow cilia and posteriorly by the palpable orbital rim. The orbital part of orbicularis is then identified by dissecting beyond the superior orbital rim. Lateral attachments to lateral palpebral raphe and medial attachments to medial canthal tendon are separated. Unlike other skeletal muscles, orbicularis oculi acts as a functional syncytium similar to a cardiac muscle. Hence, a meticulous dissection and excision of orbicularis ensures a better outcome in the treatment of spasms. Superior extent of the dissection stops where orbicularis fibers interdigitate with that of frontalis. Once the orbicularis is completely excised, Klein solution is injected into the skin overlying corrugators and procerus muscles. The corrugator muscle is identified overlying the medial third of the bony supraorbital ridge. Obliquely running fibers of the corrugator supercilii are identified with blunt dissection and is often easy to use a muscle hook to separate it. It has a bony origin medially and is inserted into the soft tissue laterally. its maximal horizontal length is dissected away and excised. Procerus is a superficial muscle overlying the glabella. It is isolated with the help of tenotomy scissor passed from one lid crease incision to the other. The blunt dissection is first carried out below the skin and a second time just above the bone. Once the muscle is separate from the overlying skin, it is excised through both the eyelid crease incisions. The levator palpebrae superioris, if found disinserted, is then reattached to the upper edge of the tarsus with 3 cardinal sutures using 6-0 proline. This step strengthens the retractors of the upper eyelid and corrects pre-existing ptosis commonly seen in long-standing cases of benign essential blepharospasm. Lid crease forming sutures are then placed by including a bite of the skin, levator edge and skin again with 6-0 polyglactin suture. 3 such sutures ensure lid crease formation. Wound is then closed with interrupted 6-0 polyglactin suture. Same procedure is repeated on the other side. Postoperatively, a substantial improvement in symptoms is noted with significant reduction in frequency and duration of spasms. Thank you for watching.
How long you have the follow-up of the patients and how many patients you have done?
Around during the training period which I had, there was about 6 patients which I have.
6 patients?
Yes.
Uh,
Because
follow-up-
we
follow-
usually do this procedure only if the patient is refractory to botulinum toxin.
Thank you.
Thank you.
The next author is Dr. Pooja Kamar. How important is to have psychology coach?
Subject matter of this video.
Hello everyone. You must be wondering who I am and what I am doing here. I am Dr. Inside, the need of the future. I wear many hats. I'm an ophthalmologist, a psychiatrist, a detective, a Sherlock Holmes who never misses a clue, and finally, I'm a healer of the mind. I was born out of growing negative opinion towards refractive surgeries. Series of reports of psychological distress, patients committing suicide, blamed on poor surgical techniques. We may have the best diagnostics, best lasers, and complete mastery of our skill, but still there is an elusive link. We cannot guarantee patient satisfaction.
The Time magazine recently published an editorial on the millennial generation. This latest generation is self-aware, tech-savvy, and have a very different mindset from previous generations.
The problem arises because we as doctors are used to studying the human brain, which we can dissect scientifically. But we need to understanding the human mind. Each person's mental state depends on their beliefs, their experiences. Its dimensions are limitless. Unfortunately, when our inner voice is unhealthy, we no longer maintain a power of reasoning.
So how can we assess the mind objectively?
A quick search online will lead you to iSync Personality Inventory. It consists of yes or no questions and grades of personality based on how extrovert you are, how neurotic you are, It also has questions to give us a falsification score. It does classify a person as sanguine, choleric, megalocolic, or phlegmatic. Of these, unstable and high neurotic scores are usually the ones who come to us perpetually dissatisfied. These patients often present to us with complaints such as ghosting, doubling of objects, ocular discomfort. We use a O3 algorithm where we do a complete ocular examination, detailed optical examination which includes topography, aberrometry, and finally an orthoptic evaluation.
So we asked 250 patients for their post-operative satisfaction. We found that 7 patients were unhappy. Majority had orthoptic imbalance. These patients were also found to have unstable personality types. But what is the connect?
The neurological control of accommodation is influenced by state of mind. The near triad depends on coordination between convergence, lenticular accommodation, and pupil constriction. An imbalance of this often triggers a visual disturbance. This can be detected by instruments to measure real-time accommodation, showing a high baseline accommodation. This is what leads to blur and double vision.
So how can we integrate this into our practice?
Patients who are noticed to display odd or aggressive behavior are asked to fill out a personality questionnaire. We also need to be very vigilant in our observation for clues in patients. We notice how they speak, continuity in their thoughts, the way they dress, the relationship they have with their family members for possible cause of emotional turmoil.
If we observe normal behavior patterns, we can go ahead with surgery hassle-free. But when we observe certain suspicious but not specific signs, we take extra precautions prior to surgery.
But if we observe outright abnormal or red flags behavior, it is better to refer the patient for professional help and defer surgery.
But referring to a psychiatrist can often be a taboo topic.
Be very careful when you use the word mental illness and blame an organic or physical cause. Be sure to have a good psychiatrist with whom you can discuss this case. You also request the patient to come for orthoptic, both home-based and office-based treatment. Let's start off with few cases.
A 27-year-old male underwent successful smile surgery for moderate myopia. 1 year later, he complains of constant discomfort interfering with his work. His topography and ocular examination were normal, but aberrometry picked up an accommodation spasm.
If you observe his scans carefully, you will notice an abnormally fluctuating pupil diameter and a consequent unstable refraction. The psychopathic control of pupil response is well established. You should rule out a personality disorder in him.
You're right, Dr. Inside. He had a high neuroticism score and on probing gave history of substance abuse and unnaturally high expectations.
Such patients require professional counseling and gradual de-addiction program for the improving their mental health, and process require patients to have the right effect. Let's discuss one more case to clarify this.
Sure, Dr. Insight. I remember a 28-year-old PhD scholar who wanted LASIK surgery, and as such, she was a viable candidate. But our trained staff noticed some odd behavior in her, and she was extremely irritated about having to wait for any small period of time.
When she met me, she told me sometimes her vision gets blurred when she is stressed, typical of pseudo-accommodative spasm. Surprisingly, her personality type was stable. She confessed she was worried about clearing her exams. My psychiatrist friend explained that every person faces times of temporary stress. We don't need professional help here. However, it is better to defer surgery till acute stress is past.
Thanks, Dr. Insight. This questionnaire helps us predict which patterns can be problematic. It also helps us decide when to take extra precautions before operating, and it prevents us from operating where the patient will never be satisfied.
Another good tool we can use is the pain catastrophizing scale. It helps us assess how a person perceives pain. We can use it for our cataract practice to decide which patients would not be able to tolerate topical anesthesia.
Only if we had known when to be cautious, we could have avoided operating in some patients, which ended up being disasters for both us as doctors and for the patient and their family.
Hey, that's all for now. I'll meet you next year with some more insights into human behavior and mind. But I forgot to tell you something. You don't need me all the time because I'm in you all the time. I'm simply a more wiser, sensitive, and insightful version of you. You have the power to be the same superhero, the insightful doctor in this video.
Any questions? Thank you. It's a very essential presentation in the current day scenario.
Thank you.
Thank you so much.
Thank you.
Dr. Kumar has a session in one of the in one of the parallel scientific halls. So he wants a session right. You also have. You also have. So you, Dr. Grover sir, can do it first. Sir will be presenting on congenital lacrimal fistula, the mysterious third gateway. After this, maybe Dr. Kumar can do it. Okay.
So this is an insight into congenital lacrimal fistulas, our thoughts and our surgical technique. I present to you the mysterious gateway to the lacrimal drainage system, the congenital lacrimal fistula. Congenital lacrimal fistula is indeed an Greetings. I present to you the mysterious gateway to the lacrimal drainage system, the congenital lacrimal fistula. Congenital lacrimal fistula is indeed an intriguing passage. We need to explore where it leads to. The path is unknown, treacherous, labyrinthine, and unpredictable. Is it a third lacrimal canaliculus provided by the nature? Let us see. A probe passed down the opening goes all the way down to an empty space with a sudden feeling of gift. As we dissect down the track, we notice a thick-walled passage, precisely like canaliculus. Once we cut the distal end, we can see the opening into another passage. Where does this track end? What are the hurdles, the obstacles that are in store for us as we explore this passage? A surgery is performed if the patient complains of watering and discharge from the fistula or the eye, as we did in this 12 years old boy with bilateral congenital fistula. Surgery begins by passing a lacrimal probe down the passage. A fine microsurgical vertical spindle is marked around the opening and incisions made with the barred Parker knife. Microsurgical dissection is carried out with a fine curved Vanna scissors, gradually and slowly. Dissection is done around all the walls. The probe in the passage provides the support for a meticulous and safe dissection. The dissection must be painstaking and slow. You can see a firm, thick-walled and fairly large, well-defined passage leading into a cavity. The location of the opening into the passage can be confirmed by passing a probe from the punctum. Here, it was seen to be in the common canaliculus. It is then excised. Let us look at the same dissection on the opposite side. Notice the thick-walled structure precisely like a canaliculus. Excision, as we notice again, opens into the lacrimal passage. You can see the lacrimal fluid coming out of the opening. The opening into the lacrimal system must be closed meticulously, and the closure must be watertight by multiple 80 Whitefield sutures. A thorough subcutaneous closure with 80 Whitefield follows. This may again require multiple sutures. Skin is closed microsurgically with 60 nylon. A thorough, meticulous surgical technique holds the key to gratifying, successful post-operative outcomes, as we see in this young boy. The mysterious gateway can and must be conquered. Thank you.
Thank you, Dr. Grover. Very excellent presentation. Thank you very much.
Dr. Kumar will be showing a video on different strokes, a new medley of little differences making a big difference.
is a medley illustrating modifications in outpatient procedures or surgical steps that can make a significant impact on the ease of doing a procedure and the eventual outcomes. Corneal foreign body removal at this video is a medley illustrating modifications in outpatient procedures or surgical steps that can make a significant impact on the ease of doing a procedure and the eventual outcomes. Corneal foreign body removal at the slit lamp is often saddled with problems such as an anxious, uncooperative patient, Bell's phenomenon in the other eye, and the Menes reflex at the site of the advancing needle. Covering the contralateral eye with an eye shield while it remains open averts the Bell's phenomenon. In addition, an external plastic eyelid retractor provides adequate palpebral widening to ease the procedure for the surgeon and alleviates hardships for the patient. The external eyelid retractor is also useful for such procedures as IOP measurement and corneal filament removal. Intravitreal injections are the most commonly done procedure next only to cataract surgery. The use of an intravitreal injection assistant made of macrolon has several advantages such as providing simultaneous lid retraction, globe stability and akinesia, local anesthetic effect from pressure, the patient being out of sight from the advancing needle, and conjunctival rotation over the injection site causing sealing and no leakage. The device has a rim for grasping and other facilities like a flange and a side tube for introducing the syringe at a fixed 23-degree angle that precludes any lens damage, and a fixed needle entry depth of 5.5 millimeters into the vitreous cavity. Our modified prototype of the above has several provisions for other injections such as Ozurdex. The principal hurdle to adequate laser PRP in early NVG is corneal epithelial edema. Mechanical expression of the corneal epithelium by rolling a cotton-tipped applicator as shown does not debride the surface, yet markedly improves the corneal clarity. Adequate laser PRP, which is the mainstay in managing NVG, can then be done to produce lasting suppression of VEGF levels, unlike the transient effects of anti-VEGFs. This simple maneuver, akin to a pin roller or a pitch roller, greatly aids in salvaging many eyes doomed to a rapid downhill course. Inadvertent corneal epithelial damage during combined buccal and vitrectomy procedures is a possibility from globe rotation and contact with the speculum. A temporary bandage contact lens employed intraoperatively prior to the steps of buckling is protective to the epithelium that leaves it in pristine condition for visualization in the subsequent critical steps of vitrectomy, for a surgeon can only be as good as he can visualize. Trypan blue dye or a marker pen can be used to mark the site of side port entry during cataract surgery in patients with a prominent arcus. This seemingly trivial step averts the need to search for and fiddle around to pinpoint the entry site location during repeated forays into the anterior chamber. This could even have far-reaching implications in preventing Descemet's membrane detachments. During side port hydration, it is not commonly recognized that translucent and many times opaque membranes in the anterior chamber obscure visualization during vitrectomy for endophthalmitis. Careful prior removal of these, as shown in this video bit, paves the way for a clearer viewing of the murky vitreous cavity in this scenario with likely better outcomes. The elastic stringy exudates are often copious, and maximum removal has added benefits of preventing zippering of the angle and recalcitrant secondary glaucoma. Various maneuvers to clean up the anterior chamber before proceeding with vitrectomy in endophthalmitis is akin to cleaning up a soiled or foggy windshield before proceeding on a long journey. In patients on anticoagulants and those with bleeding diathesis, inadvertent surgical iris trauma can result in a steady, unresponsive, troublesome ooze. Using a small gauge endodiathermy at the site can save the day and the eye. In high hyperopes and patients with shallow anterior chambers, vitreous upthrust during cataract surgery can be a bugbear. Inserting a 23 or a 27 gauge cannula through a trocar of the MIVS system allows egress of fluid vitreous without any active traction on the vitreoretinal interface. The opening can be plugged when necessary to maintain intraocular pressure. Thus, a trouble-free surgery is ensured. The scleral plug acts as a safety valve for subsequent decompression if necessary. Air bubbles entering the anterior chamber from a visco syringe is a perpetual irritant and a decelerator in surgery. Removing air bubbles from the anterior chamber would also entail additional viscoelastics and wastage. To overcome this, some of the precautionary steps include tight fixing of the cannula, smaller bore cannulae, and keeping the syringe immersed in a sterile container with sterile irrigant in between surgical steps to prevent air being drawn into the cannula when it is exposed to ambient air. To conclude, it's the little difference that ultimately makes the big difference. And the big difference between ordinary and extraordinary is only that little extra, which, as we saw, could provide extra benefits to us and to our patients. And the endless common sense modifications are only limited by our imagination. Thank you, sir.
Thanks, sir. Wonderful presentation. Who all are having parallel sessions? Dr. Kasturi, anyone else? You are, doctor? Okay. Dr. Kasturi ma'am first, then Dr. Ajay Arora, then you, then the rest of you.
So thank you for permitting me to present in advance. Thank you.
Thank you. So Dr. Kasturi Bhattacharya will be presenting on lower lid blepharoplasty, paradigm shift from orbital flat
Details of
sculpting
lower
to
eyelid
fat relocation
blepharoplasty,
and redraping.
thereby highlighting a paradigm shift from orbital fat sculpting. This video will show the surgical details of lower eyelid blepharoplasty, thereby highlighting a paradigm shift from orbital fat sculpting to fat relocation and redraping. None of the authors have any financial disclosures or conflict of interest. We all know that the most common indication of lower eyelid blepharoplasty is a double convexity deformity. The double convexity deformity is characterized by prominence of the orbital rim, lengthening of lower lid surface area and bowing, and herniation of the orbital fat. When this defect is more prominent medially, it is known as teardrop deformity, and likewise, if prominent laterally, it is known as hollow eye deformity. The common indications of lower lid blepharoplasty are relative steative blepharon, infraorbital or malar deflation, malar mounds or festoons, and lower eyelid asymmetry. The most important contraindications are unrealistic expectations, coexisting unstable medical conditions, active thyroid ophthalmopathy, and uncontrolled dry eye syndrome. Historically, lower lid blepharoplasty was a reductive surgery that involved excision of variable amounts of skin, muscle, and fat from the eyelid in order to reduce lower eyelid wrinkles, skin redundancy, and fat bulges. The most common deformity that develops due to excision of the fat pads in lower lid blepharoplasty is relative depression near the medial orbit in the area of the lower eyelid midface transition, shadowing in the location of the orbitomalleary ligament, thereby accentuating the tear trough deformity, and sometimes an additional surface depression in the area of septal confluence. This is a 48-year-old lady who reported to our institution for treatment of the puffy eyes with bulging of the lower eyelid due to the prolapse of the lower orbital fats, and thereby leading to transition of the positive vector to a negative vector. Accordingly, she underwent a conventional lower lid blepharoplasty with sculpting of all the 3 fat pads. However, there has been shadowing in the location of the orbitomalleary ligament, along with accentuation of the tear trough deformity and additional surface depression in the area of septal confluence. So the question is, how to correct or prevent such iatrogenic deformities? And the best answer to it is filler augmentation after conventional blepharoplasty. So this patient was injected with hyaluronic acid filler in the tear trough region and in the region of depressed septal confluence with a 25 gauge cannula. Thus, we could achieve a beautiful correction of the post-blepharoplasty tear trough with injection of hyaluronic acid filler. Herein in the front view, we can appreciate how fresh, young, and rejuvenated she looks. However, another option to prevent post-blepharoplasty tear trough depression is retraping and relocation of the orbital fat from the orbit inferiorly to SOOF. Herein the authors present the result of a prospective consecutive comparative study of 150 patients, that is 300 eyelids, wherein 150 eyelids of 75 patients underwent the bilateral conventional lower lid blepharoplasty with sculpting of 3 fat pads, and another 150 eyelids of 75 patients underwent bilateral lower lid blepharoplasty with redraping and relocation of the 3 orbital fat pads into the SOOF compartment after releasing the orbitomalar ligament to efface the lid cheek junction. To perform the lower lid blepharoplasty, one should have a very clear understanding of the anatomy. We all know that the lower eyelid has 3 fat pads, wherein the inferior oblique muscle divides the medial and central fat pads, and the outward expansion divides the central and lateral fat pads. In the 3-dimensional view, the central fat pad lies much anteriorly as compared to the medial and lateral fat pads. The surgery starts with a transconjunctival incision given approximately 4 mm from below the tarsus. This is followed by separation of the subconjunctival tissues and incision on the inferior orbital septum. This exposes the infraorbital fats. Careful dissection leads to identification of the 3 fat pads. Herein, the inferior oblique muscle can be visualized separating the medial from the central fat pads. Once the 3 fat pads are fashioned, next is to release the orbitomalleary ligament, which is an osteocutaneous ligament, followed by relocation of the fat pads to the SOOF compartments. A 6-O-proline suture is used to fix the relocated fat pad in the upper midface and tied over bolsters. Very often, a small nick is given in the superior lateral lid crease of the upper lid, through which lysis of the inferior arm of the lateral canthal tendon is done, and then placement of lateral canthopexy sutures to tighten the lower eyelid. Thus, at the completion of the surgery, we can appreciate the effacement of the lid-cheek junction along with correction of the lower lid laxity. Post-operative results showed that in Group A, 90% had deepened tear trough deformity along with a negative vector, and Group B, 100% showed effacement of the lid-cheek junction with correction of the malar hypoplasia, thereby reverting the negative vector to a positive vector. These are a few of the happy Group B patients who had undergone suborbicularis retraping of 3 lower fat pads along with lateral canthopexy during lower eyelid blepharoplasty. Thus, the present trend follows a tissue-preserving philosophy, which includes orbital and SOOP relocation and fat transfer techniques to restore apparent volume loss associated with patient aging. Relocation of the orbital fat not only corrects the tear trough and provides a long-lasting change in the contour of the lower eyelid, but it also adds to the advantage of utilizing autogenous tissues. Thus, this video highlighted the evolving paradigm shift from the traditional fat sculpting to retraping of the orbital fat pads in lower eyelid blepharoplasty. Thank you very much.
Nice video, ma'am. Any questions from anyone?
How long have you followed up these patients?
Sir, it's almost followed more than 5 years. Initially, I started doing blepharoplasty for more than 12 years, and the initial technique was only to cut the fats. Then when I was following my patient, I have realized that only by removing the fats, I'm leading to more of the development of negative vector and hollowing. So we have shifted this surgical technique now where we translocate the whatever the fat is there, we do not cut it, but relocate and bring it right from the orbit to the SOOP region. And by now, most of the patients will be more than 5 to 6 years follow-up.
Are they happy after 5 years or it is reversed?
They're happy, sir. Definitely.
No, do you need resurgery after maybe 5 years?
Those patients initially whom I have only excised the fat, these are the patients who comes to me, they say, yes, my swelling has gone off, but I feel that there is a hollowing. So these are the patients which I have supplemented by injection filler. But when I realized my own studies, for the last 5 years, we are doing only translocations of the fat.
Right. Thank you, ma'am.
Thank you.
Dr. Ajay Arora. After that, Dr. Ajay Arora will be presenting a video on suprachoroidal drug injection simplified.
This is a new technique. Drugs are delivered to the eye systemically and locally. Local treatment options include drops, periocular injections like peribulbar and subtenons injection, and intravitreal injections. And recently to this has been added the suprachoroidal injections. Drugs, when injected intravitreally, overcome the blood-retinal barrier and hence have a greater bioavailability to the retina and choroid. However, they can produce endophthalmitis, cataract, and glaucoma. The suprachoroidal space extends from the ciliary body to the optic nerve. When steroids are injected in the space, they will not produce cataract because they do not come in contact with the lens, and glaucoma because they do not come in contact with the trabecular meshwork. But they are available much more to the retina and choroidal tissues. However, the catch is the use of microneedle, which is depicted here, which is not easily available commercially. The options are a proprietary microneedle microinjector system developed by Clearside Biomedical, which has needle of 900 and 1100 microns length with a bevel of 300 microns. This device, when available, is likely to be expensive, especially in the developing world. A second method is microcatheterization of the suprachoroidal space, which was developed by Medvan but is no longer available. The normal commercially available 30 gauge needle, which has got a bevel of 1200 microns, cannot be used for injecting in the suprachoroidal space if it is directed perpendicular to the sclera, because this would introduce the needle into the vitreous. So is there a way out? Yes, this may be achieved by an oblique entry of the needle into the sclera. So this is the concept that if the needle enters vertically, that is BA, it will traverse shorter distance as compared to when it enters the sclera obliquely. Here it is 30 degrees angle to enter the suprachoroidal space. So this is basically the concept of my new suprachoroidal injection device, in which a 30 gauge needle can be used for injecting drugs in the suprachoroidal space. This device went through various versions of improvement. The present device that is available and is being used has a handle, a base plate which has got an undersurface which is rough to allow its placement on the sclera without any slippage, a needle sleeve which allows the needle to guide through up to the sclera, and a visualization window which allows the bevel direction to be adjusted before it touches the sclera. Now here is an example of the device being used in the goat's eye to test a hypothesis where the triamcinolone injection has been made. Following this, the sclera is carefully dissected and we discover that triamcinolone is located in the suprachoroidal space. You can see the whitish triamcinolone in the suprachoroidal space. The hypothesis was further tested by injecting methyl cellulose and helon in the goat's eye and tested by UBM. There was maximum separation obtained when injected with helon. Our next step was to inject triamcinolone in the human eyes, and an informed consent was taken from the patient. You can see here suprachoroidal injection being made with the device in the human eyes where triamcinolone is injected, and at the end of injection we can hardly make out where this injection was made. Here is another example of two eyes where the SCITA injection is being done. This is a list of about 10 cases where SCITA has been done. 9 out of these 10 cases responded extremely well with reduction of the macular thickness. So this is a 58 years obese female who is a diabetic and hypertensive, pseudophakic in both eyes, and has got a laser proliferative diabetic retinopathy. She's received 8 injections of Avastin and Lucentis in both eyes, followed by 4 injections in each eye of Ozurdex. And recently, when Ozurdex was not available, she presented with a persistent cystoid macular edema, which was quite significant in both eyes. She underwent suprachoroidal injection of triamcinolone with a dramatic response when she presented on day 14, and now she's been followed for over 70 days and still maintains a flat retina. Similar experience has been obtained in other cases. So suprachoroidal space injections are the future for retinal and choroidal pharmacotherapy. The good part about suprachoroidal injection device which is being presented here is that the recurring cost is only €3, 3 cents for the needle and about €2.5 for triamcinolone. Based on the scleral thickness, one could change the angulation at which the needle will hit the sclera and at the point it will enter the sclera. So the suprachoroidal injection device is an all-drug device. It is autoclavable, can inject drugs at varying depths. It can be connected to a mechanized injection system. The recurring cost is minimal. There is no scleral incision required, and it can be used in cases of suprachoroidal buckling. Ladies and gentlemen, I welcome you to a novel and simplified way of injecting drugs in the suprachoroidal space using a hypodermic needle. It is safe, the drug is delivered in the suprachoroidal space consistently, and above all, it is cheap. The window in the needle sleeve allows adjustment of the position of the bevel. We recommend a bevel down entry. If you are in the correct plane, you will not find resistance to injection. Our experience in this pilot study has been encouraging. On your left is persistent DME 2 weeks after injection, the macula is flat. On your right is post cataract surgery cystoid macular edema reduced the next day. Indeed, a wow effect. Thank you.
Thanks, sir. But what do you say about the steroid response? I mean, the IOP rise, is it lesser than routine posterior subtenon strike-on?
So this particular condition, the suprachoroidal space, is bounded anteriorly by the scleral spur and posteriorly by the optic nerve. So the triamcinolone does not come in contact with either the lens epithelium or the trabecular meshwork. Hence, till now this is what 10 eyes, we have done 74 eyes now. There was not a single case of glaucoma, not a single case of cataract. There have been some reports from Chicago where they've shown very minimal triamcinolone they have detected, which made a minuscule level, which may have percolated through the circulation, but they have not been able to detect any drug which can affect the trabecular meshwork. So it is, we have used it in cases of glaucoma, we've injected who have had a retinal problem and the IOP has not risen. And now we have devices available. I have a nomogram which so you can inject it even in myopic eyes with thin sclera. So we have a nomogram where we go inside with the depth, the whole track is 1300 to 1400 micron, and so there's a nomogram based upon the thickness. We normally do HD OCT thickness of the sclera and then decide which device to use.
What would you say about the learning curve?
My co-worker is a retina surgeon who is in Shroff Charity, who did work with me, Dr. Shalini, and she initially had for 2-3 goat size, and then she was able to do it, and then it's possible to do it in cases. It's not a problem. My people who are working with me have also learnt it, so it's possible to inject.
Particular feeling once you entered the suprachoroidal space, or you are still in the sclera?
So the concept is very simple, sir. If you are in the sclera, you will have a resistance, you will not be able to inject. But once you are in the suprachoroidal space, even if the tip of the needle in the suprachoroidal space, it will just flow through. And that is the basic concept behind the whole device. So people are making devices. There's a jugaad of a 23 gauge needle with a 30 gauge needle. So the problem comes up is that these needles can leak from behind, and triamcinolone can come out. People reuse these needles, so there can be infection. Here, everything is disposable. The device is autoclavable.
Thank you.
Thank you, sir.
Thank you, sir.
Dr. Jay Shet, okay, you're there. So Dr. Jay Shet will be presenting a video on endophthalmitis. Is it really the end?
Endophthalmitis is a catastrophic complication of any intraocular surgery necessitating urgent management. We present a case of a 67-year-old gentleman diagnosed with suspected endophthalmitis on first day post-cataract surgery based on clinical evaluation and ultrasound sonography. He was planned for an anterior chamber wash with exudative membrane removal, with a vitreous biopsy, debulking vitrectomy, and intravitreal antibiotics as demonstrated in the subsequent video. At the onset, 23 gauge 3 ports were made. AC wash was done with Simcoe cannula. Dense exudative membrane was noted. which was removed with the help of an end-grasping forceps and sent for microbiological evaluation. Vitreous biopsy was performed using a cutter with its tip in the pupillary axis as pointed by the finger. Since the tip of the infusion cannula could not be visualized, a handheld infusion cannula, as shown by the arrow, was maintained in position by the assistant and was utilized for irrigation. A debulking vitrectomy was carried out. This was followed by intravitreal injection of vancomycin and a combination of piperacillin tazobactam through the pre-existing 23-gauge ports. The culture came positive for Pseudomonas aeruginosa. Subsequently, there was significant worsening with development of total corneal abscess and a retinal and choroidal detachment. For this, the patient underwent a therapeutic keratoplasty with choroidal drainage with vitrectomy and silicone oil injection as illustrated in the subsequent video. After the 360-degree peritomy, a large corneoscleral trephination was done. Flaring ring was utilized for globe stability. The diseased corneal tissue was excised and the PCRL that was stuck to its undersurface as pointed by the finger got delivered automatically. A large therapeutic graft was sutured and the flaring ring removed. An AC maintainer was utilized for infusion. With the help of a 23-gauge cutter, debulking of the exudates was performed from the anterior chamber and the ciliary body area. (23-gauge) 2 ports were made in the superotemporal and the superonasal quadrants. A careful, controlled vitrectomy was initiated. Underlying pre-existing retinal and choroidal detachment was noted as shown by the finger. We also had an iatrogenic break as pointed out. At 7 mm from the limbus, we performed choroidal drainage with the help of a MVR blade partially inserted through the sclera in the nasal and the temporal quadrants respectively. Next, we perform a fluid-air exchange through the iatrogenic break to settle the retina, followed by silicone oil injection. On inspection, areas of retinal necrosis and hemorrhage were noted. the peritoneum was closed. Based on the microbiological sensitivity, intravitreal injection of vancomycin and a combination of piperacillin and tazobactam was performed. At the end of 2 months, the patient had a reasonably good recovery with a visual acuity of counting fingers 2 meters and attached retina and absence of any disease activity.
Yes, thank you.
Yeah, what about the follow-up?
So I think
How
the
long?
patient has a 1-year follow-up.
1 year.
1-year follow-up till
No
date.
redetachment.
No redetachment, sir. There was that single iatrogenic break was there, so that we utilized to do the fluid air exchange. We could do a good laser also around it, so no redetachments till date. Patient has a
What
vision.
about oil? Did you put oil?
Yes, sir. Oil.
Oil is still there?
Oil is still there, sir. The patient is aphakic. Oil is still there, and I think has vision of 3 meters.
And you said that in the first surgery you had done a debulking vitrectomy.
Yes, sir.
Why was the visualization poor during the first surgery?
Yes, sir. The visualization was quite poor because there was a dense membrane was there in the AC that we removed, but still it was still quite poor visualization. So only a core vitrectomy was done to just reduce the amount of bacterial load from the eye.
Visualization was much better than that of the second surgery.
So in the second surgery, because we had an open, because the PKP was done, so the cornea was very clear. And once we removed all the exudates from the anterior chamber and in the pars plana area, so the things became much more clear. We could go behind and see that.
Why did you take the risk of putting needle through the clear graft which you have put infusion? It hasn't affected the clarity of the graft?
No, sir, it's not. Okay, thank you.
So we call next person, Dr. Tarjani Dave, secondary volume augmentation in anophthalmic sockets.
Adequate volume replacement in socket surgeries in the primary sitting is of utmost importance to provide a suitable bed for a well-fitting prosthesis. It ensures that the tone of the eyelids is maintained and the superior sulcus does not have a hollow appearance. Methods for volumizing include implant exchange, dermis fat graft, subperiosteal implants, autologous fat transfer, and injectable soft tissue fillers. Secondary volume replacement in a socket that is sans implant is best achieved with the help of a suitable ball implant. The surgical process involves making a conjunctival incision to raise 2 flaps of the conjunctiva, the superior and the inferior flaps. The anterior Tenon's capsule is dissected in a similar fashion. The posterior Tenon's capsule is dissected with cruciate incisions in the 4 oblique quadrants to preserve the extraocular muscles. The central intraconal space is carefully exposed to place the implant accurately. The wound is closed in 3 layers, starting with the posterior Tenons, then the anterior Tenons, and finally the conjunctiva. In situations where there is associated surface loss with volume loss, the fornix needs to be deepened with fornix formation sutures. 3 sets of fornix formation sutures are taken on both the eyelids. The size of the residual surface defect is measured and marked on the lip mucosa. The edges of the mucosa are dissected using a radiofrequency cautery, and the base is dissected using a combination of blunt and sharp dissection with scissors. The bed is covered with amniotic membrane graft. The mucosa is transferred to the bed of the socket and secured with 6 cervical sutures in a running fashion. A conformer is placed and suture tarsorrhaphy is done. Alternatively, dermis fat grafting can help in cases that have combined volume and surface loss. The preparation of the socket bed stays as discussed in the secondary implant video. The dermis fat graft is harvested from the buttock. The required measurement of the dermis fat graft is marked and an incision is made with a number 15 blade. The epidermis is dissected off from the dermis using a shaving blade or a number 15 blade. A number 11 blade is then used to incise the fat along the dermal incision to harvest the desired volume of the dermis fat graft. The donor area is closed in 2 layers with 4-row vicryl suture for the deeper tissue and a 4-row proline running suture for the surface. The dermis fat graft is transferred to the anophthalmic socket. Oversizing the graft by 30 to 40% is advantageous. The graft is secured to the edges of the conjunctiva with a 6-row vicryl running suture. Fornix formation sutures may be added if the fornices are shallow. An adequately sized conformer is placed and a suture tarsorrhaphy is performed. In cases with pure volume loss, the volume augmentation can be performed with subperiosteal implants. This technique is especially useful when volume loss is associated with inferior implant migration or floor fractures. This technique is especially useful when volume loss is associated with inferior implant migration or floor fractures. The surgery involves making an inferior transconjunctival incision midway between the tarsus and the fornix. The incision is deepened till the white band of the lower eyelid retractors is visible. Using a Stevens scissor, the inferior orbital rim is palpated and the scissors are opened just within the orbital rim. Dissection is done in a hand-over-hand fashion to expose the floor of the orbit. The dissection stops just short of the apex. The Porex wedge implant has a groove to accommodate the nasolacrimal duct. The wedge implant is introduced in the correct orientation, avoiding tissue drag. The anterior edge of the wedge implant should lie just within the orbital rim. The implant is secured with cyanoacrylate glue. Fat transfer uses liposuction to remove fat from an area such as the abdomen and transfer it to the eye socket. This technique involves creation of a stab incision in the umbilicus and introduction of fat harvesting cannulas. The cannula is connected to a lure lock syringe and suction is maintained within the syringe to manually harvest the abdominal fat. The direction of the cannula is maintained such that it stays in the subcutaneous fat pocket. Once the desired quantity of fat is harvested, the syringe is disconnected from the cannula and kept inverted in a glass beaker. The serum is discarded and the fat is injected into the eye socket as a retrobulbar injection. Considering about 50% of fat necrosis, overcorrection of the enophthalmos is aimed for. Hyaluronic acid gel injection is a minimally invasive treatment modality for the correction of anophthalmic enophthalmos. The prosthetic eye is removed and the pre-filled syringe is loaded on a 24-gauge needle. The filler is injected carefully into the retrobulbar space, avoiding an overfill. the patient resumes the use of the prosthesis immediately post-procedure. We have discussed all the available options for volume augmentation in anophthalmic sockets in this video. Thank you for watching our video.
Any questions? Okay, thank you, Doctor. Dr. Satish Kumar is there. So he is presenting a video on big data, big change.
The authors have no financial interests. Our world is facing a cataract crisis. Ensuring optimal surgical outcomes when patient volume is high remains a persistent challenge in a variety of healthcare settings. In 2015, Hostrup et al. Found that audits tracking surgical outcomes are not enforced currently in most hospitals, making quality assurance yet another obstacle. According to reports worldwide, there are a multitude of clinical information systems, but very few surgical outcome monitoring systems. The Aravind Eye Care system currently does more than 3 lakh cataract surgeries per year. In this high-volume scenario, manual data collection can be time-consuming, inefficient, and inaccurate. In 2013, we pioneered the Cataract Surgery Outcome Monitoring System, CAT-QA, to monitor our own performance and to produce highly accurate data about how our patients fared after surgery. CAT-QA allows surgeons to measure themselves. With just a few clicks, they can view a summary of their own operative outcomes, as well as changes over time. They can even compare their individual data with their colleagues' performance. CAT-QA especially helps trainees assess their status and improve their learning curve by understanding their individual performance. Chiefs and administrators can compare parameters with other hospitals in the database. This type of benchmarking is essential to understanding an institution's strengths and weaknesses and ensuring quality. Let's see how CAT-QA works. Here is the opening screen where credentials are entered. Features of the system include summary data, master's data, and benchmarking data. There are a number of factors that contribute to the uniqueness of CAT-QA. It is one of few such registries in the world for cataract surgery. The feature of automatic report generation saves time in searching for results. With one click, a user can track the outcome of specific groups of patients, benchmark surgical outcomes with surgeons in all available cataract indicators, compare one specific surgeon's data with surgeons in different hospitals of similar size, compare the hospital's overall performance with other hospitals in the CAT-QA system in all available cataract indicators, access a comparative summary data report which shows different types of cataract surgeries performed, different types of anesthesia used for patients and any associated complications, and data regarding intra-op complications, post-op complications, resurgeries, early and late post-op residual refractive error, and endophthalmitis incidence. Additionally, CAT-QA can show a graph for each surgeon trending 2 or more cataract indices selected, and compare these indices graphically with average and highest performing surgeons. A monthly report of all cataract indicators is routinely sent to each surgeon through an email delivery system. What is the impact of this monitoring system? Let's visualize this situation in the surgical flow based on CAT-QA generated data. 87.9% of the population has less than 1 diopter post-op spherical equivalent refractive error on average in all of our hospitals. To increase this further, we changed our biometry method from the applanation method to the immersion method in non-paying patients, SICS category. This resulted in change to an average of 93.26% within 2 years. Anesthesia-related complications are few in number when compared to the number of cataract surgeries we operate on. In order to reduce them from few to nil, we changed from peribulbar or retrobulbar anesthesia to subtenons anesthesia in 2016. Now the incidence is almost nil. Astigmatism should be properly dealt with to get best postoperative uncorrected visual acuity. Other than using a toric IOL, we made a decision to mark surgical incisions in the steep axis preoperatively on the IOL master sheet. When compared to 2017, data of 2018 showed a 5% increase in patients attaining a vision of 6/9 or better. Reducing the trainee complications is one area that Aravind is concerned with. 2016 CAT-QA gave us percentage of complications happening during surgical training through all our hospitals. We came up with the SAFE approach. It's a novel, cost-effective, yet simple device for ophthalmic surgical wet lab training. In 2017, there is a 20% reduction in complications seen. Endophthalmitis is always a nightmare for every surgeon and institution, and a feared complication of ocular procedures. Haripriya et al. Reported that with the usage of intracameral moxifloxacin at the end of surgery, the incidence of endophthalmitis has been reduced from 0.07% to 0.02%. This landmark paper has changed practice patterns not only at our institution, but across the world. And it is the direct result of having access to this wealth of data through CAT-QA. Evidence-based changes in patient care made our patients more satisfied. Till today, CAT-QA holds almost 1.7 million patients' surgical data. What's on the horizon for this kind of big data? In the era of artificial intelligence and machine learning, big data can lead to big change. For example, artificial intelligence can now diagnose diabetic retinopathy and predict cardiovascular risk factors, all from a simple fundus photo. Perhaps big data from our CAT-QA, used with deep learning algorithms, can one day predict surgical outcomes and improve ophthalmic care. If today we are experiencing this big change, we can be sure that bigger changes will be coming down the road.
Dr. Shalu Bageja will be speaking.
Furthermore, chances of migration or extrusion is lower with the use of autologous tissue than the use of the artificial implants. The most commonly cited drawback of the procedure is an unpredictable rate of subsequent fat atrophy. This instructional video demonstrates a step-by-step approach in a young patient who had an evisceration socket without implant with a shallow inferior fornix. The conjunctival incision is given in the center, extending from the medial to the lateral canthus. It may be combined with the lateral canthotomy if one wants to increase the horizontal palpebral aperture. The subconjunctival dissection is carried out towards the eyelid margin as well as deep into the orbit towards the orbital rim. Minimum cautery should be done so that the vascular supply is not compromised. Once the dissection is carried out, we can see the scleral shell along with the recti muscle. All the 4 recti muscles were hooked and anchored with 60 vicus sutures and then inserted from the scleral shell. We can use the anchoring sutures of 5th cycle so that the conjunctiva can be retracted and we can have a better exposure. Once all the 4 recti are disinserted from the scleral shell, the scleral shell is opened up and the opening is made in the posterior part so that the posterior tenons can be exposed and which facilitates of the deeper placement of the fat graft. The dermal fat graft was harvested from the lateral aspect of the buttock. 20 mm diameter of circle was marked. It can be done in an elliptical shape also, which can snugly fit into the socket. Epidermis was incised and removed with an 11 number blade. Epidermis is removed to the depth that the pedicle bleeding is seen. Holding the blade perpendicular to the dermal surface, an incision is made along the dermis to the underlying fat. Then Stevens scissors are then used to excise about 2.5 cm depth of fat. Approximately 30 to 50 excess graft tissue should be harvested as there are chances of fat atrophy post-operatively. Once the graft is harvested, it can be placed in the saline solution along with the antibiotic. Proper undermining is required to have a good closure. Closure is done with the 3 ovicular sutures in multiple layers. Here we can see the donor site is well apposed, and then the skin suture with 4O silk is given. Then the graft is placed in the recipient bed. All the 4 recti are sutured to the edge of the dermis with the prior anchor 60 ovicular sutures. It is a double arm sutures, so both the ends are sutured to the dermal surface. It may not always be possible to locate the recti muscle, and then we have to just push the graft to have a good volume in the deep into the socket and close the conjunctival edges to the dermis. Once all the 4 recti are sutured, then we can suture the conjunctiva and tenons to the edges of the dermis with 60 ovicular suture. Here we were able to separate the tenons, thus we have doing it in a 2-layer closure. The tenons is sutured, conjunctiva is meticulously sutured to the edge of the dermis with 60 ovicular suture. After the conjunctival closure, the fornix forming sutures are applied with 40 silk sutures, which is passed from the proposed depth of the fornix to the orbital rim, taking a bite of the peri-orbita. The sutures are passed on the skin over the bolster. 3 fornix forming sutures are given in the lower lid and 2 in the upper lid. Once all the sutures are passed, place the properly sized conformer into the socket, and then the sutures are tied over the bolster. This is the immediate post-op of the patient. This is the 1 week post-operatively, showing the minimal edema and the good healing of the graft. This is a pre-operative picture showing the shallow inferior fornix, and the satisfactory epithelialization of the graft is taking place. Once the dermis is fully epithelialized, the patient was given the prosthesis and showed a satisfactory result post-operatively. Thank you.
Questions? Any questions, sir? Thank you, Dr. Shalu. Dr. Salil Kumar Mandal will take us on a journey from hell to heaven.
In the subject matter of this video.
This is not my video.
VT34.
Large upper eyelid tumor with severe maggot infestation. This is a live maggot inside the tumor mass. Here is 73 years old female complains of big mass in the right eye since 1 year. It was painful and bleeds on touch. Due to poverty, old age, and family ignorance and negligence leads to lid cancer in advanced stage, infested with maggot. At this situation, the patient feels alone, helpless, gradually moves towards death. The life is almost in hell. This is a live maggot which runs, and the life is almost hell. In this situation, patient feels helpless. The patient ultimately came into the guards of the hospital. The doctors removed maggot with daily dressing, plan for removal of tumor with upper eyelid reconstruction, total tarsal plate replacement with autogenous auricular cartilage. This is a modified cartilage procedure which is planned. Poverty, old age, family burden, negligence leads to more advanced stage of the lid cancer with the maggot infestation. Skin is marked first, and large mass involving the entire upper eyelid is planned for removal. Here the rectangular incision planned which encircle the tumor mass all along with 4 mm healthy margin. Large mass involving the entire upper eyelid is removed and sent for HP examination, which is a sebaceous cell carcinoma in origin. Full thickness incision made over the healthy tissue far away from the cancer zone with the help of a radiocautery. Rectangular upper eyelid defect created after removal of the large tumor. Vertical skin incision made over the back of the ear pinna to expose the ear cartilage. Here the skin and subcutaneous tissue is dissected and well cleavage to expose the glistening surface of the ear pinna. And 30 mm of ear cartilage is harvested with an elliptical shape from the ear pinna. This elliptical shape is similar to the tarsal plate, that is the ideal material for tarsal plate replacement. Your wound is repaired with a 4-0 black silk. 4 to 6 mm below the upper border of the lower lid, rectangular advancement flap made, which is passed below the hammock flap up to the upper border created defect. Advancement flap splitted into anterior and posterior lamina. Posterior lamina consisting of conjunctiva and capsulopalpebral fascia, and the anterior lamina consisting of a skin orbicularis oculi. Again, the upper lid again splitted into anterior posterior lamina. Posterior lamina consisting of conjunctiva and orbital septum, and the anterior lamina consisting of orbicularis oculi and the skin subcutaneous tissue. So the posterior lamina of the upper lid and the lower lid sutured to make the posterior lamina bay. Over that, the autogenous ear cartilage is fixed with a 4-0 polygalactin suture. Here the cartilage is fixed. Full thickness rectangular created defect closed by rectangular advancement flap. This is defect is closed. Second stage of the cutler beard after 3 months. Advancement flap is well stretched. Iris repositor pass below the well stretched advancement flap to prevent the corneal injury during flap opening by a radio cautery. Here the upper lid is prepared for blinking action. Now it is open and it is free and it is ready for excursion of the lid. Upper lid border closed by a double suture of 6-0 polygalactin, where the knot is placed at the lid skin surface to prevent the suture related corneal complication. Here the raw edge of the advancement flap sutured with the raw edge of the hammock flap, thus inferior fornix is formed. This surgical procedure was functionally, cosmetically, anatomically accepted, and the patient's psychological and social status is highly improved. She enters into the stage from hell to heaven. This is the look of the patient. She is suffering from a malignant tumor. Now she is fine. New hope, new life, new vision, feel good like heaven. Thanks.
Great presentation, sir. Any questions from the audience? Thank you. Thank you so much. I think we have the last presentation, last video Dr. Lakshmi K.S. should be showing a video on oblique enigma.
Demystifying the superior and its surgeries. Superior oblique is a little like this image. We know it's there, but it's fuzzy. Our aim is to make it beautifully clear. The anatomy of superior oblique is as unique as everything about this muscle. The course of superior oblique is topsy-turvy. Superior oblique has an anatomical origin from the lesser wing of sphenoid bone, and physiological origin is the trochlea, a cartilaginous U on the superior middle wall of the orbit. Its insertion, superior quadrant, underneath the superior rectus muscle with its concavity facing the trochlea. Its actions are depression, abduction and intorsion. It is supplied by the trochlear nerve. Anterior 1/3 fibers of superior oblique are responsible for intorsion and posterior 2/3 for depression and abduction. Superior oblique weakening surgeries are tenotomy, tenectomy, partial posterior tenectomy, superior oblique tendon expander, superior oblique split tendon elongation, and strengthening procedures are full tendon tuck and Harada-Ito procedure. Indications for weakening and strengthening are shown above. Most important indication for weakening is Brown syndrome, and the most important one for strengthening is congenital superior oblique palsy. The weakening procedures of superior oblique: partial posterior tenotomy. It is performed as shown in the video above. The superior oblique tendon is isolated temporal to the superior rectus muscle. Posterior 2/3 of the superior oblique tendon fibers underlying the superior rectus muscle insertion are incised. The superior oblique tendon expander procedure. This is the most commonly done procedure for overaction of superior oblique as well as Brown syndrome. The thick tendinous cord of superior oblique muscle is isolated nasal to the superior rectus muscle. Two non-absorbable sutures are secured on the tendon. The tendon is cut in between the sutures. A medical grade silicone 240 band is cut to the desired length, and double-armed sutures of the cut ends of the superior oblique tendon are then passed in a horizontal mattress fashion through the segment of silicone band. The length of the silicone band depends on the amount of superior oblique overaction. Superior oblique strengthening procedures. Superior oblique tendon tuck procedure. This is done in case of congenital superior oblique palsy, where there is a lax superior oblique tendon. The folded tendon is tied together with 5-0 muscle non-absorbable double-armed suture passed in a mattress fashion. Intraoperative force duction testing can be carried out to find out if the tuck is too tight, too loose or adequate. Harada-Ito procedure. The principle is tight cracking of the anterior fibers will induce intorsion without too much change in depression and abduction. Its only indication is a partially recovered superior oblique palsy where there is a large degree of extorsion. There are two types, classic paradiato and disinsertion paradiato. Here, we have shown the disinsertion paradiato procedure. The sheet of superior oblique muscle tendon under the superior rectus is isolated. The anterior fibers up to 4 mm are separated. A non-absorbable suture is passed beneath the separated superior oblique tendon. Tendon is then disinserted. The anterior fibers are separated from the posterior fibers for 6 to 8 mm from the insertion. The suture is then passed at the superior border of the lateral rectus muscle, 8 mm posterior to the lateral rectus insertion, and tied. Intraoperative adjustment can be done using fundus examination. Understanding the superior oblique muscle and its surgeries can be confusing, just like watching experts solve the Rubik's Cube. Hopefully, this step-by-step video bouquet of all the superior oblique surgeries has made it simpler to understand as well as enjoy the workings of the superior oblique muscle. Thank you for watching the video.
Now we come to the end of the session. All videos presented, I think all were present. All have been marked, and are we supposed to declare the result? We'll send the result to scientific committee. Scientific committee will take the final decision. Individual judges will send the marks to scientific committee, right? Okay, thank you all.
Anybody from